All right, let's jump straight into high-yield hematology for Step 2CK, specifically tackling hemostasis, coagulation, and transfusions. We're going to dive right into differentiating bleeding patterns.
When you're looking at a bleeding patient on the exam, your absolute first move is to triage based on the bleeding pattern. It's incredibly straightforward. Mucocutaneous symptoms, things like petechia, epistaxis, menorrhagia, or immediate mucosal bleeding, strongly indicate a defect in platelet number or function. On the flip side, deep tissue bleeding, like hemarthrosis into a joint space or delayed large hematomas, points you straight toward coagulation factor defects.
Take a look at this. These classic petechiae and that purpuric rash scattered across the legs, that's a massive red flag for a platelet disorder. These tiny, non-blanching red spots tell you there's capillary bleeding that normal platelets would usually plug up. When you see this, you need to work up the platelet issue. Remember, decreased production comes from things like chemotherapy, myelodysplasia, alcohol, B12 or folate deficiency, congenital marrow failure, and infections. Meanwhile, increased destruction includes immune, mechanical, and medication causes, or even splenic sequestration and dilution after a massive transfusion. So what if you see isolated thrombocytopenia? I'm talking platelets below 100,000, but every other cell line is totally normal. That's classic immune thrombocytopenic purpura, or ITP. If you look at the peripheral smear, you'll see just a few normal to large platelets. Your next best step here is absolutely crucial. Mandatory screening for HIV and hepatitis C, because secondary ITP can actually be the very first way those infections present.
Now for the branching logic on managing ITP. If it's a kid with just isolated skin findings, you simply observe. Adults with mild cutaneous symptoms and platelets at or above 30,000, you observe them too. You only escalate to glucocorticoids, IVIG, or anti-D if there's active bleeding or if those platelets drop below 30,000. And keep in mind, platelet transfusions are strictly reserved for life-threatening hemorrhage, period.
Moving on to TTP, or thrombotic thrombocytopenic purpura. The big villain here is a decreased ADAM-TS13 enzyme, which is often from an acquired autoantibody. Without it, you get these massive, uncleaved von Willebrand factor multimers circulating in the blood. They act like nets, trapping platelets and causing thrombocytopenia. Plus, you get microangiopathic hemolytic anemia with schistocytes, renal injury, neurologic symptoms, and fever. The emergency management here, urgent plasma exchange.
Then we have hemolytic uremic syndrome, or HUS. You'll almost always see this right after a bout of bloody diarrhea from Shiga-toxin-producing E. coli 0157H7 or Shigella. These patients develop hemolytic anemia, thrombocytopenia, and acute kidney injury. Your next best step is supportive care with fluids and electrolytes. Do not give antibiotics or antimotility drugs during the diarrheal phase. That actually increases the risk of HUS and is strongly contraindicated.
Contrast that with DIC. This is widespread coagulation activation, usually triggered by something massive like sepsis, severe trauma, or an obstetric complication. The labs are a mess. Prolonged PT and PTT, low platelets, low fibrinogen, and sky-high D-dimer. The rule here is to treat the underlying cause first. You only replace factors with FFP, cryoprecipitate, or platelets when active bleeding or procedural risk absolutely demands it. Okay, let's talk about heparin-induced thrombocytopenia, or HIT. You've got to suspect this the second you see a patient's platelets plummet by over 50%, exactly 5 to 10 days post-heparin exposure, or even sooner if they've had recent exposure. Think of the 4T score. You're looking for that specific timing, the drastic percentage drop, maybe a new venous or arterial thrombosis, or a systemic reaction, and no other obvious cause for the low platelets. If you see a necrotic skin lesion exactly where they got a heparin injection, that is a classic trigger telling you to look for new arterial or venous thromboses. What's happening is the immune system is reacting to the heparin platelet factor 4 complex. It activates and clumps the platelets, dropping the count and blocking vessels, which is what causes that tissue necrosis. For the next best step in emergency management, you need zero hesitation. Stop all heparin instantly. Yes, even the flushes and the low molecular weight heparins. Don't sit around waiting for the confirmatory serotonin release assay if your clinical suspicion is high. You need to start a non-heparin anticoagulant like argatroban or fondaparinux right away. And, crucially, you only start them on warfarin after the platelet count has completely recovered. Now, what happens when you're evaluating deep tissue bleeding and you see an isolated prolonged PDT? You do a coagulation mixing study. You mix the patient's plasma 1-to-1 with normal plasma. If the PTT corrects, you're dealing with a factor deficiency.
If it fails to correct, you have a coagulation inhibitor on your hands. And as a quick side note, von Willebrand disease can also give you a prolonged PTT, but that's going to present with mucosal bleeding and is treated with desmopressin. A prime example of an inhibitor you'll be tested on is the lupus anticoagulant. It's actually an antiphospholipid antibody that binds up the phospholipids used in the lab test. So it artificially prolongs the PTT in the test tube, even though it's causing a prothrombotic state in the actual patient. And because it's an inhibitor, it will not correct on a mixing study. Jumping back to deep tissue bleeding, check out this radiograph showing hemophilic arthropathy. You can see the narrowed joint space and subchondral cysts. This is a super painful classic complication of hemophilia A or B. They present with a prolonged PTT, but a totally normal platelet count. If you did a mixing study here, it would correct to normal because it's a factor 8 or 9 deficiency, which you treat with targeted factor replacement.
So, what if you see an isolated prolonged PT and INR? That strongly points to vitamin K deficiency. This is usually driven by malnutrition, fat malabsorption, underlying liver disease, or giving flora-depleting broad-spectrum antibiotics. The platelets will be normal. Now, regarding iatrogenic causes, if a patient has serious bleeding from warfarin, you reverse it with IV vitamin K plus prothrombin complex concentrate. If they just have a high INR without bleeding, you manage it by holding the warfarin and maybe giving oral vitamin K depending on the exact number. And remember, unfractionated heparin is reversed with protamine when you need rapid reversibility. And don't forget newborn physiology. A baby who misses their intramuscular vitamin K shot at birth is going to classically present with bleeding on days 2 through 7 of life. Infants have super low vitamin K stores to begin with because it doesn't cross the placenta well and their gut is sterile. Without that preventative shot, they are at huge risk for severe umbilical, gastrointestinal, or even intracranial hemorrhage. Now let's flip it to hypercoagulability. If you're working up a DVT or PE, remember that factor V Leiden is the most common hereditary cause in patients of white ethnicity, and it's due to activated protein C resistance. Also, protein C or S deficiency significantly increases the risk for warfarin-induced skin necrosis. When you're picking an anticoagulant, keep in mind that low molecular weight heparin and factor XA inhibitors are problematic if the patient has severe renal insufficiency. And if the patient is pregnant, heparin products are preferred because warfarin is teratogenic. All right, let's nail down blood product logic. You've got to memorize these platelet transfusion thresholds. Prophylactic platelet transfusions are strictly reserved for counts below 10,000 without active bleeding. If the patient is actively hemorrhaging, that threshold shifts up to 50,000. Outside of those parameters, or very specific surgical indications, you withhold the platelets. Finally, let's talk transfusion reactions. If you suspect any reaction, your very first step is always to stop the transfusion immediately. Now, if the patient develops respiratory distress, an elevated heart rate, high blood pressure, and pulmonary edema within 6 hours of a rapid infusion, you are looking at transfusion-associated circulatory overload, or TACO. You have to distinguish this from TRALE, which gives you hypotension, and anaphylaxis, which involves shock and bronchospasm but no fluid overload. You also have acute hemolytic, bacterial sepsis, and febrile non-hemolytic reactions, all separated by their exact timing and symptoms. Timing and hemodynamics dictate your absolute next best step.